Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
Today's episode is going to be a little different. It was recorded live at the JSOM-TC during the July 21st Joint Trauma System teleconference. This time we have Dr. Doug Powell. He's going to be talking about providing critical care in austere environments, and he's been doing this for about 2 years with us. He's proctored and instructed more prolonged field care and other austere medical exercises than anyone else I know, and he's now a battalion surgeon in a Special Forces group. He's got a pretty good idea of what's required of a special operations medic. All of the downloads he talks about today are available for free at prolongedfieldcare.org. And now, on to the podcast.
Thank you. I'm giving my talk today from the Joint Special Operations Medical Training Center here at Fort Bragg, which is a regular participant in these conferences, and I can't emphasize enough how much these conferences contribute to the training of our special operations medic. Before getting into a discussion of how we teach austere critical care monitoring and management, I'd like to briefly review the strategic and operating concepts that are context that are driving these initiatives, and that can help explain why they're so important in current and future special operations medical initiatives. Pretty much every strategic document in Army Special Operations, and now the new U.S. Army operating concept, predicts that we're going to be sending smaller and smaller teams to more and more places in the future. This is sometimes referred to as gray zone conflict. There are going to be some publications coming out about the medical implications of gray zone conflict, and for the purposes of this talk, this really has three implications. First off, it's impossible, both from a manning standpoint and really a financial standpoint, for AMED health support to put assets in support of every mission, just because there's so many, they're so dispersed, and the casualty rate is very low density. So the implication of that is that more responsibility is going to fall on soft medical providers to be able to provide initial critical care, resuscitation, and stabilization. And really, the point of impact is going to be the special operations medic, because they'll be, in almost every case, the only person within that golden hour to assess and stabilize their patients. And then finally, as this conference today is really a great example of, in these operating environments, penetrating trauma may not be the leading cause of critical illness and injury. We're seeing blunt force trauma be much more prevalent in medical conditions such as infection and environment. This is really the slide that we use to brief commanders in our community of the implications of changing from an operating environment in which we had very mature medical assets in place to more of an immature medical environment. You can see we've overlaid the United States with Africa. This could also apply in other environments where we operate, such as islands in the Pacific and other dispersed environments, where it's just not possible to get critical care assets and critical care surgery assets, shown in green, in anywhere near the 1 to 2 hour time frame or to the casualty as we did in Iraq and Afghanistan. And it's most likely we're looking at definitive care not being available for 1 to several days. Prolonged Field Care Working Group, with whom it's been a privilege to work for over 2 years, has worked closely with our soft medical allies in NATO and other countries, and come up with this as a definition for prolonged field care. The one point I'd like to make is that these recommendations and these techniques and practices are really aimed at independent duty medics. And while the Army operating concept does forecast a need to develop austere care capabilities, conventional forces, medical assets, nothing in our recommendations and nothing in my talk today is really applicable to the conventional forces medic. It's really independent medical provider or credential provider and higher. We talk about 4 stages of prolonged field care. It's important to note that these are not linear. and not all may be in play in any particular casualty or any particular operating environment. But it is important that we prepare to provide stabilization and resuscitation of critically ill and injured patients at every level, because you never know which one you're going to run into in your environment. A couple points about this. We have a line of communication that I'll get to on a future slide that's called ICU in a Rucksack. That was kind of what this talk was billed when Colonel Sean Keenan and Colonel Shackelford invited me to come and participate here. I want to clarify that it's really possible to provide ICU level diagnostics and monitoring in a rucksack, but when you get into the management, it's not really possible because you're going to exhaust your supplies pretty quickly. So at that point, we really should be transitioning to one of these stages where you can cache supplies, or another aspect of prolonged field care, rely on some improvised techniques, which we also train. Just over a year ago, the USASOC Medical Training Group ran a prolonged field care assessment exercise here at Fort Bragg, and this was really designed to answer the question, do we need to refresh prolonged field care skills in our existing 18 Delta, in our existing Special Forces medics? Because, of course, you know, the guys at the schoolhouse will say, well, they've all been trained on that. Of the nearly 400 critical tasks that an 18 Delta has to be trained on and accomplish before they graduate, there's a large number of them that pertain to prolonged field care. But what our suspicion was and our observation was that after 10 years of sort of adrenaline-driven, very trauma-centric care in Iraq and Afghanistan, where we're pretty much stabilizing at the point of injury and handing off to medicine and having decompensation happen either en route or at the cache or the FST, is that these skills had not been sustained. And so we invited teams of medics from 5 of the Special Forces groups, ran them through 2 lanes of about 18 hours each, one that was more surgery focused, one that was more ICU, critical care stabilization or resuscitation focused. And we picked about 40 of these critical tasks that we were going to assess, some being more TCCC and some being more prolonged field care oriented. And consistently at the bottom of the list of a self-administered survey, both before and after the exercise, the prolonged field care tasks ranked as the ones that the medic had the least confidence in applying. And this was also something that was eye-opening for command in terms of getting their awareness of the importance of training dollars, but really more importantly time, because time is the most precious commodity in our community, set aside and dedicated to prolonged field care training. Before I get into the hows and the whats of how we train critical care in austere environments, I start all of these trainings by explaining the why of patients can decompensate, and sort of the why of the golden hour. And the physiologic context is systemic inflammatory response as it leads or can lead to circulatory shock. And it takes some time when we're training the medics to explain that this potential really exists with any significant mechanism of illness or injury. We saw it in our heat casualty patient today. We see it in infected patients. One in a bigger lecture that I give, the example of the vitals that we trend is actually a heat casualty that occurred here at Fort Bragg. And make the point that the only tool that we have to improve outcomes in the progression to circulatory shock is early recognition that the patient's decompensating, so we can jump on them with treatment of the underlying cause and appropriate resuscitation. So here's the famous ICU in a Ruck, which a slide that I gave at SAMHSA in a talk this year, and it points to the fact the most important information that we use to make decisions about patient care in a critical care setting can be obtained from vital signs, mental status, neurologic status, pain status, and with the addition of just a Foley catheter to give us one window into organ perfusion. And the most important thing in this slide is actually sitting underneath all of that, and that's a way to record all of these trends so we can monitor them and react to them if we spot decompensation. This is an example of a flow sheet that we make available to the medics. They use it here in the schoolhouse. It was developed by one of our fantastic instructors, Sergeant First Class Paul Los, and is one of the plank holders in the Prolonged Field Care Working Group. It's available on the Working Group's website, which I'll give at the end of the talk. And this is really probably the first key management skill that we teach for providing austere critical care, is vital signs trending. The second key skill that we teach is relying on checklists. And it may be too small on the slide, but like I said, you can get a copy of this. It's a PDF file. We have a checklist on the right that the medics can follow and are encouraged to follow when they get into stress decision making and fatigue as these exercises or actual patient care, gets beyond the 24-hour mark. On the back, some of the other skills we train are the development of problem lists with plans matched to problems and handoffs, because there's the potential for several handoffs to occur, both to non-medical team members as the medic has to rest, and to flight crews and other care providers en route. And as we all know, in clinical medicine, handoffs are one of the greatest areas of risks for the patient. Another really important skill that we've developed and that we teach and that we encourage, and a capability that we've developed and need to develop further, is teleconsultation. And so if we as AMED providers and military medicine providers can't have the patient come to us in our ICU, no matter how far forward, we can at least virtually bring the ICU to the patient. And the model that we looked at when we developed teleconsultation for prolonged field care was really the call system that all of us have trained in hospitals. And when you think about it, we've managed for years and years and years, physicians have managed complicated, unstable patients very well with voice communications, not even with email data to support our voice communications. And that the key aspects of this are to have the right people to talk to at the other end of the line to help us manage our patients, and be able to present data that helps them help us. And that's being able to collect trends and present trends. In October of last year, we rolled out a pilot project called the Virtual Critical Care Consultation Line, or the VC3 line, in collaboration with intensive care docs at the ISR burn unit. This is an unsecure voice connection directly to an on-call staff intensivist with a dedicated email address where the medics could send data, specifically snapshots of the flow sheet, pictures of wounds, and pictures of what we call capabilities, which I'll get to in a minute. We tested this with almost 100 training calls and exercises all across the SOF community. We refined it, and we've actually employed it in the SOC Africa area of responsibility, and have had to this date at least 5 real-world calls with improved outcomes in all of them. And we're going to publish some case reports in the Journal of Special Operations Medicine later this year. The big issue for us as a community is to sustain this. It's really been kind of an ad hoc project. There's not really a TDA position for a VC3 doc on anybody's MedSen roster, but somehow get docs to participate and get the software to call forward to docs so we can sustain this and expand it to all special operations AORs and all branches of the military with special operations missions that are ongoing. As I said, one of the key parts of good teleconsultation is being able to present a patient, and we work pretty carefully and extensively on developing a script. I've blacked out the actual contact numbers to VC3 on this more open source format, but this generic flow sheet is also available on the working group website. One of the key capabilities or key things that the medics asked for was a way to convey to the doc on the end of the phone what their capabilities are where they're treating their patient, because they really were concerned that hospital-based physicians for information that they just didn't have the capability to provide. And so the bottom right is what we call the capabilities worksheet. The medic can very quickly fill out what they have in the way of meds, resuscitation fluids, airway capabilities, procedural capabilities, etc. Email this off to the doc so they can start to form a little bit of a picture of the environment in which the casualty is being treated when they answer the call. This isn't really a hospital critical care capability, but it's one that's developed as we, pretty much from the first exercise we ran in the fall of 2014, we pushed medics and teams to the point of exhausting their supplies, and really from the very first exercise, some great improvisational techniques came forward. The one that came out of that exercise was one of the medics asking, hey, if I'm out of IV fluids, can I resuscitate my patient, either orally or using rectal fluids? Because I have water available and I can sterilize the water or I can boil the water. I just am out of IV fluids. And that led us to look in the literature, and we've actually found case reports of rectal fluid resuscitation of hemorrhagic shock patients, and a pretty extensive body of literature that I cite in one of the sources at the end of this presentation on oral and enteral resuscitations of burn patients that really kind of dates from the Cold War era, looking at nuclear mass casualty events. So that was a pretty helpful improvisation. We teach those techniques all the time. You can see in the lower left-hand corner a simulated burn patient sipping rehydration fluid through a straw made from cut-down IV tubing as he's resuscitated in exercise. Some of the other things have been a little bit more innovative. On the right, there's an improvised condom catheter that actually did hold water. We get right up to the line, but we don't actually put them on our simulated patients. But that was ginned up by one of our teams, and it actually worked. It's a exam glove connected by IV tubing and taped to an empty IV bag. At the top is an improvised bag mask that uses a pool toy inflator hooked up to the top of a soda can, sealed with tape and padded. And then in the bottom center is an improvised 3-jar chest tube atrium that one of our surgical colleagues, Dr. Dave Harden, who's currently at Baylor in Dallas, showed us based on his extensive humanitarian surgical experience in Africa. And then finally, last but certainly not least, in terms of important ICU techniques that we're teaching is nursing care, because we will have these patients for long enough for complications to develop, and as we all know, the complications can often be as serious or potentially more serious than the initial insult itself. I'm going to wrap up on the last 2 slides by talking about how we can train austere critical care, some opportunities for the military medical community to get involved with this, with the special operations medical community. And on the last slide then, some techniques that I found to be really helpful for optimizing the clinical ICU experience for austere critical care if you do have a special forces medic who's rotating in your ICU. So the first thing I'll say is that with more of an emphasis on critical care and prolonged field care training, and really the most important thing is to get into ICUs and see sick patients, because there's nothing like seeing decompensation firsthand and learning about it from a trained physician and a trained nurse to understand, to recognize it when you have it facing you in an austere location. So medical proficiency training is something that all of the 18 Deltas and independent duty corpsmen have to go through 2 weeks in a hospital environment every 2 years. One of the big gaps that we're identifying is we probably could use some critical care and critical surgery training for our physician and physician assistant providers, because many of them come from backgrounds where they're not managing complicated patients, and this would be an opportunity that we could put a battalion surgeon, his PA, and senior medic together in an ICU for a week, training with trauma surgeons, acute care surgeons, intensivists, to really get some valuable training in the management of unstable patients. At unit level, we have both non-trauma modules where we're giving hands-on demonstration or talks, and here's a great opportunity for guest speakers to come in and contribute to the education of our medics. At pretty much any site that has a special operations unit, there should be that opportunity, and your point of contact should be the group surgeon or the squadron surgeon. And then field exercises, and like I said, what we're finding to be the most useful model is developing, first off, realistic cases, and we actually extrapolate from some of these cases in this conference to create scenarios that we train on these exercises. So that's been one of the contributions of this conference to our training. Having good mentors, people who take care of complicated patients for a business, is really helpful. There's value in having expert medics, there's value about having expert medic trainers, but all of the guys have said that they really value the contributions of the surgeons, the anesthesiologists, critical care providers who come out and help mentor the lanes. We want to make this austere. This is one of the forcing functions for improvisation, to make them run out of things and come up with a plan, both for conserving the assets that they have, prioritizing who gets the material that they have, and then for improvising when they run out. And we found that we can't really provide a good prolonged field care training experience or austere critical care experience in an exercise lasting less than 24 hours. a couple of the important things that happen at this point is, number one, the medic gets so tired that he has to put his head down. And so that forces a handoff to non-medical team members and, if then wake criteria, which is an important thing to have. And it also forces stress decision making and fatigue decision making. And all of us who've been through fellowship and had 24-hour and 30-hour calls, know that as tough as that was, it definitely contributed to our development as providers. And then the last aspect of good field training is to have multiple movements. Number one, to simulate a realistic exfil from any of our operating environments, and number two, to kind of test their ability to provide cares on all the different Ruck, truck, house, plane platforms that we talked about earlier. And pretty much every event now we try to integrate some sort of air, fixed wing or rotary wing. I'll finish up with really the realization that brought me to prolonged field care in the first place, as I came to WOMAC as a new intensive care doc and had a couple of students in black sweats with this funny crest on them show up in the ICU, and I asked them who they were, and they said, well, we're 18 Delta students, sir, and we're here to learn. And what I realized pretty early on in training the 18 Delta students in the Q course here at the schoolhouse was that critical care is much more of a thought process than it is about equipment. And a technique, and I was guilty as a young practitioner of what I did as a fellow, was that when I pre-rounded, I'd sort of say, well, I gotta go get my numbers, go get your coffee, go get your breakfast, and come meet me for rounds. And then realized pretty quickly that pre-rounding is really where we do all of our thinking. And if thought process is important, is what we're trying to teach these guys, then they should be involved as we develop our thought process, because rounds is really just a validation and a little bit of tweaking of the thought process, but we really make most of our assessments as we pre-round. So now we have them come in, and some guys will just come for pre-rounds. They'll come in, bring their coffee, we'll review all the patients in the ICU, and a refinement has been, first we review only the data that they have available at that Ruck level. So, mental status, pain, vital signs, urine output. We go through all the patients like that. We triage them from sickest to least sick, most stable, least stable to most stable. We look at trends. Are they getting better, staying the same, or getting worse? And only then will we integrate, more advanced data from labs and radiology and consultant studies. And probably 8 times out of 10, we don't have to revise our initial assessment that we made with Ruck level diagnostics with these more advanced, and that gives them a lot of confidence that they can rely on the tools that they have with them to take care of complicated patients. Usually then we'll round, and they can see the benefit of bringing a team into the care of complicated patients. We'll have some sort of didactics. If I cover only one topic, in an academic lecture, I'll talk about the systemic inflammatory response and circulatory shock. And then in the afternoon, pair them up with one of our ICU nurses to go through the work of caring for a critically ill patient, rolling every 2 hours, doing Foley care, doing IV care, doing patient hygiene, so they can, number one, learn some techniques, and number two, see how exhausting it can be. And this is a perfect thing for them to hand off to their teammates when they're caring for a patient, is, anybody can be taught to roll a patient safely and keep them clean, and that's one of the tasks that we encourage them to delegate if they're in a real-world prolonged field care environment. I'll just finish with some of my favorite quotes from mentors in the prolonged field care realm. The first, if you can't bring the patient back, you have to push the capability forward, and that's really what we're all about in a prolonged field care working group, and with the topics I've talked about here. Sergeant Major, recently retired Mike Hetzler, said that the best austere care is great clinical care as applied as close as possible to hospital standards. We improvise only when we need to, and what we try to encourage is high standard hospital level critical care, and deviate that only if we have to, and not make improvising and winging it a default. And then the last thing is from my new commander, who said critical thinking is a key skill for all special operations forces. And one of the things he likes about the medical training that we're doing is that we teach critical thinking, and critical thinking is not something that he can surge. You can't send somebody to a class to teach them to critical think. It really is a process that needs to be developed, and so he's seeing benefit in medical training, not just for risk reduction, but for teaching our guys to be better thinkers. And with that, I'll end. The Prolonged Field Care Working Group website is on this slide. have any questions, in the last page there's some resources for journal articles that we refer to when we teach, and then some prolonged field care specific clinical practice guidelines that we're working on with the ISR that shall be published this year. Thank you very much.